Good morning, everyone. This is Healthcare. Could somebody close the door, guys? Today is Friday, January 16th. And we have in with us, we're talking about hospitals and hospital budgets this morning. First, want to offer congratulations to our ranking member, Daisy Rebecca, for her stellar bill report today on our first bill that came to the floor. Thank you.
First interrogation of the year.
I know. Right, anyways, we have Matt Sutter in with us for, I'm sorry, Matthew.
That's fine.
Matt, we've got Matt Sutter in with Green Mountain Care Board with us to sort of go through a presentation on hospital budgets and maybe give us some insight into what happened this year and can have a seat.
Thank you, folks. Give me 1 second to get the slides pulled up. Sounds good. All right, thanks for having me in, folks. I'm going to provide an overview of our budget process. Very broadly, our history of hospital regulation in Vermont, kind of an overview of how we review budgets and the role of benchmarks. They get a lot of attention, and just kind of go over last year's decisions and then kind of talk about next steps. But I do want to make this kind of open for I'll tell you this, but open for conversation. So please stop me at any point. I'm happy to answer questions. So why regulate hospitals? I think you've seen this slide before. We've used this in a number of places. Why regulate hospital budgets? So hospital spending, it's no surprise, it's a major driver of healthcare spending in Vermont, and it's increasing. This is showing in the green bars here showing 2018, the blue 2022. So you see an increase there. We don't have numbers for 2026 yet to show, but I would bet it's a higher concentration in hospitals. I was betting on it still. So this, coupled with the fact that we basically have one hospital and one insurer dominating the market in Vermont, makes regulation very important. So I promise a very short history of the regulation in Vermont. So in 1983, Title 18 established the hospital budget review process to slow rising costs of healthcare in our state. And also for hospital budgets were reasonable and fair. In 2011, Act 48 gave Vermont new tools to apply the hospital budget review process designed to manage costs, including the creation of the Green Mountain Care Board. And then in 2012, hospital budget oversight was assigned to the Green Mountain Care Board. And then I included Act 68 from last year, which tasked the Green Mountain Care Board with achieving payment reform through reference-based pricing. So I will talk a little bit about that at the end, kind of our strategies next year and kind of moving forward. But I know we have a more detailed report due to you following up on Act 68. I want to let our policy team speak in more detail about RBP going forward. But so real high level, our budget review process, the board's tasked with establishing hospital budgets that meet the state's statutory objectives. And these objectives they're laid out in statute, but they broadly relate to increasing access, improving quality, and containing costs in the system. Each year, the board establishes benchmarks for hospital use in developing and preparing budgets and to guide the board in its decision-making. Hospitals bear the burden of persuading the board that their proposed budget aligns with state's statutory objectives. And the board also votes on standard budget conditions that apply to all hospitals. Some examples of that might be reporting requirements. So, for example, we have in the budget orders, right, they're required to report their monthly actuals to us. For the exact language, it might be in accordance with how staff wishes to receive it or something like that. But we do have standard budget conditions that apply for hospitals. So timeframe wise, this time of year, my team is developing a draft version of guidance to share with our leadership, public and stakeholders, and that has to be adopted by the end of March. So in the past, typically how that's worked is staff would work really hard putting together guidance. We would release it at a board meeting, present it to the board. Everyone would go back. We would have a meeting the subsequent week or a couple of weeks later to review any changes, talk about any, just discuss guidance and any changes folks want to see. I think what I tried to do last year was really just move it up a little bit. Add an extra meeting in there so that we have a little bit more substantive discussion around guidance. And this year, I think we're going to do it even earlier. So what we're really shooting for this year is to have a draft version of guidance by the end of January published. It wouldn't be presented yet. We want to socialize it, make sure all stakeholders can see an initial draft so that when we come to the first GMCB hearing around it, we can have more substantive discussions and everyone's kind of on the same page there. Yeah.
Do you see hospitals, like, I'm assuming you don't do any quarterly work, like, do you only see this once a year? So you're not watching like the monthly budget reports or anything throughout the year?
No, we actually, so that's a great question. So in the past, what we've done is received quarterly updates from the hospitals where they would send us a kind of less detailed than we get in the summer, but a kind of a reduced budget submission with like an income statement, a balance sheet, and update us quarterly. Knowing that the system is kind of, I'll use the word crisis. Last year, we changed it to a monthly reporting. So hospitals now need to report directly and adaptive, which is our budgeting system, in the same format that they give us their initial budget submission, full monthly actuals, P&L, income statement, a balance sheet. And then every quarter, we ask them to provide a narrative explanation of major changes. So the goal here is that we can provide more timely updates. We're currently trying to stand up some reporting for this, so I'm happy to come back when we have that ready and discuss it and really like socialize what we want to see out of that reporting. I can mention I've spoken to a gentleman down in New Jersey. They stood up what they call an early warning system down there, where it looks at basically the same metrics that we kind of look at, but just days cash on hand, like operating margin. So it's kind of very high level metrics at all their hospitals to keep an eye on solvency issues. So I would like to do something. I don't have anything concrete to discuss right now, but that is something we're actively working on producing.
I think Leslie had a question for you.
I come from Wyndham County, so thank you for this, really helpful. So Grace Cottage, Brattleboro, Springfield, so hospitals on the edge.
Yeah.
A couple of years ago, legislators would go to our meetings with these, and they were really frustrated and feeling like some of the reporting was onerous and hard for them to keep up with. So I'm just wondering if you've had an opportunity to work with them and see how that's evolved.
Absolutely. So big highlight is we're going to be very intentional about what we ask for from hospitals. In the past, I think what I've told hospitals, we've been having individual meetings with them to kind of just get a level set from last year. I like to learn what we did, hear their perspective. Asking them to report the same thing that we ask Grace Cottage for everything doesn't always make sense, right? There's some reporting where it's very important that we receive it from the UVMs. Grace Cottage, not as much. Maybe we're a little more intentional around what we ask. And that's what I would say. Right now in guidance, we are talking about having different reporting requirements for different types of hospitals, knowing that it is a burden, a lot of our reporting requirements, and it's important that we receive the information we do, but it is a burden on them and want to make sure it's worth it.
Mm-hmm. Yeah, that they learn from it too. I mean, hopefully that's what I'm imagining, that it's just not this one way, that there's dynamic sort of interaction.
Yeah, absolutely. And I told them I'm always an open. I want to hear input from hospitals on how we can improve our process. Because, yeah, definitely.
Thank you.
Are the quarterly or now monthly financials, is that available publicly on the website?
It will be. So right now it's submitted through Adaptive. They didn't start reporting, and one of my team members is going to correct me. I want to say, December might be the first month that we started receiving them. So there's a little bit of delay before we start spinning up the receipt of the actuals. But it will be.
All right, thanks.
I can't commit to like a dashboard or something like that yet, but there will be some public reporting.
Yeah. It'll be buried somewhere in the
Maze, yeah.
Yes.
Labyrinth, yeah.
Mhm.
So I just wanted to hospital finances are very complicated. And I think we talk about benchmarks and use terms like NPR, net patient revenue, or commercial reimbursement, or operating expenses people kind of generally have an understanding of. But I thought maybe it'd be helpful to just kind of really high level go through like what a profit and loss statement of a hospital looks like in some of these categories. I won't belabor any of these, but the top line there where it says gross revenue, what I like to think of here is these are the charges at the hospital. This is not actual revenue that they're collecting. This is the charge, basically this is the charge master amount. And below that, you have something here, I just grouped it all. There's deductions, there's different types of deductions, but for simplicity's sake, this is largely, think about commercial insurers, right? You get a bill from the charge master, and then there's got some reimbursement, there's some negotiated deduction off of that amount that the insurers pay. So the full charges are reflected there in that gross revenue, but then the deductions off of that are how you get to this net revenue, what the hospital actually receives from the payer. NPR is typically, and NPR is distinct from other operating revenues since that it's direct hospital patient care revenue. Below that, sorry.
Does that include the patients or is it just the insurance?
It's anyone. So it could be self-pay. It's kind of agnostic as who's paying it, but it's patient care revenue. FPP or fixed payments for essentially the same purpose of that patient. This is also patient care revenue, just delivered in a different way. So for our regulatory purposes, we focused on revenue caps and treating the NPR and FPP as like grouped together. And what we'll typically look at is we set incremental budgets, right? So in guidance, we would set a growth rate for NPR that we are comfortable with. And then as hospitals submit budgets, we would check it against the guidance we set and if unjustified, adjust their budgets accordingly. I just wanted to highlight where that is in like a P&L right there. Below that, you would have other operating revenue that sums up to their total operating revenue. Deduct expenses, you get your operating income for the year. Importantly, though, at the bottom here, I want to really be clear that we have been establishing the same benchmarks for all hospitals. I don't think we're going to be doing that going forward. So why have we?
Can I go
Yes.
back to that?
Yeah, that's the thing.
When you come out March 31st, typically you're like 3.5%, everybody. This year, you're intending to say, Dr. Leffler, you get 0.2%. Springfield, you get 47%. So you're gonna do different ones this year.
Yeah, I can't commit yet to exactly how the station will be broken up, but there will be some different benchmarks for different classes or categories.
Looking forward to it.
I am too.
Yes, of course.
And I'm sorry that I came in late, if you already said this, but why are you switching that philosophy?
You teed me up perfectly.
Oh,
Right.
okay, great.
Yeah, thank you. So what do we targeted through revenue benchmark? What's the goal? We've basically tethered it to all payer model targets. In theory, the idea being that budgets that met this would contain costs in the system. What's actually happened, though, is that NPR has grown much faster. So here I just took from 2017 actuals, trended forward at 4.2% growth versus the actual growth. The solid line is the actual, dotted line is this is the trend forward. I do want to really quickly mention, though, on this slide, the 25 period is the projections we received in the summer, and the 26 are the submitted budgets, not the approved budget. So very important distinction, especially for Dr. Leffler, it kind of overstates some of the increase for 26. So you can see there's a almost $300 million difference there. If you look at 2026 between what hospitals submitted and where we would have expected them to be and growing at 4.2%. Getting to your question, if you break it out by hospital type, tells a little bit different story. Most of this discrepancy has been at the academic medical center. So you see some difference there between the critical access hospitals in yellow, the mid-sized community hospitals in red. Really, that gap between what we've been targeting has been at the academic medical center. And then if you look at this cumulatively, right, it becomes more dramatic. So if we look at the area below and above the line, the difference between the 4.2% trend and what actually occurred, this is, since 2017, a massive amount of money we're talking about here, above what we kind of targeted through the all-payer model. So we've been setting the same benchmarks, getting very different outcomes from different types of hospitals. I think it's kind of clear, we can't keep doing that.
And I think the key is there are different types of hospitals,
Yeah.
right? So, yeah, okay.
And I'll
Doing different things.
yeah, exactly. And it's not just NPR, right? We have an operating expense benchmark now. Does it make critical access hospitals are reimbursed very differently than the PPS hospitals or the AMC? Want to avoid any kind of unintended consequences of capping their operating expenses. So in these one-on-one meetings I've been having with hospitals, I want to say it was in northeastern Vermont, but one of the critical access hospitals told us, like, look, this might cause us to deflate our depreciation and our schedules because we want to hit your cap. It might if they deflate their depreciation expense to hit our cap, it might affect how much they get reimbursed by the feds. So we really want to be intentional with our benchmarks and for stuff like that, just be knowledgeable about it so we can adjust for it. I'll say last year we told them from the outset, provider tax, we're not going to count that against you in terms of judging your submission against our operating expense benchmark. So really open to hearing more from hospitals and stakeholders about things like that, because we are trying to avoid those sorts of unintended consequences. And here's just an example of like the decisions we made last year. So you see that column with benchmarks, flat 3% versus the hospital proposed, and then what was ultimately approved. So in aggregate, hospitals came in under our 3% benchmark. But we have to review hospital budgets against this, statutory criteria and whatnot. And eventually it came out effectively what was approved was a 2% rate cut across the board, aggregated across the system. You have to basically weight each of these individual decisions against the size of the hospital, but effectively a 2% cut just from hospital budgets.
Can we go back to that one?
Yeah.
So the first hospital, of course, is Brattleboro Memorial. Have they had their budget approved? Because haven't they had to come back a few times?
So this is kind of nuanced, but I'm happy to talk about it. So Brattleboro, when they came in the summer, we had, and I'll put if anyone has a chance, we had a hearing on Wednesday where Dave Sandel, their consultant, came in and gave an update to the board about their finances, but we had a number of issues with their filings where numbers weren't tying out or making sense. We ultimately approved a level funded budget for them. And because of solvency concerns, basically gave them, if you see that 2.4% that we approved, that's the system average approved. Once you back out UVM, UVM's like kind of the reason it's a negative 2% is because of that UVM pulling it down. But the 2.4% is about the system average. We had genuine solvency concerns at VMAs. We couldn't make really heads or tails of their submission enough to adjust their NPR, allow more NPR growth. So it's sort of nuanced in the sense that we approved a budget for them at a level fund with a 2.4% rate cap. Their resubmission is below that cap because they have inflated revenue projections. So they're still below the cap we established for them. So they don't really need a new budget to be approved, as so long as they stay beneath the caps the board already established. Is that
That's
convoluted enough for you? Okay.
Yeah, just, I knew that there were problems with, their budget and go ahead, Leslie.
So I'm from that area, so pay attention. And they've asked to be exempted from, and I'm not going to remember the number, but our price caps for outpatient drugs. What would be the process for that?
Through the board, just on the technical process, would be to submit a mid-year budget request with increased commercial rate. So I think the way the statute is worded allows for the board to increase commercial rates if they demonstrate. Don't quote me on it, but there's some.
When they make a request.
Yeah, there's some things they need to meet in order to make that request. That's I think the approach they have to take from a just technical angle.
Yeah.
They have not made that request.
Not
yet, but that's what's in the news.
And I will say they submitted a budget this summer without the ASP cap in there. That was one of those concerns we had and called out during the hearing. They kind of told us they were part of this rural community hospital demonstration that would, forgive me for not knowing details, but would sort of reimburse similarly to how a critical access hospital would. And I think they made some inferences there that because of that, the CA exemption then apply to them, that just is not the case.
Tupper?
Could you go over, the University of Vermont Medical Center? I can't make heads or tails of. You include something and then the minus 6 point something.
Sure. So
How I understand that.
yeah, so the hospital proposed increase was 2.4%. We ultimately approved negative 6.4. So the way mechanically it works is the board has to make a determination around their budget. The board found, I don't quote me an exact amount. I want to say, I'm sure Dr. Leffler, I want to say $95 million NPR cut, 90 million, 95 total. $90 million NPR cut, all taken from reduced commercial rates. So took that $90 million, basically converted it to what it would have been in terms of a commercial rate reduction, and then put that in the budget. So that negative 6.4% approved would effectively pull $90 million out of their submitted budget to the board.
Thank you.
I promise I did not set it up so that all the seats were taken when Dr. Leffler came in. Because it's.
Our co-trustee, yeah.
Sorry, can I clarify that? So 90 million off of what they proposed? Or that's what
Correct.
okay.
Yeah.
So they went up a something, whatever million, and you ultimately went down, and the whole thing there is
Yeah.
90 million.
Yeah,
Okay.
and the math with the rate to NPR conversion gets very nuanced and complicated, but yes.
Okay, thanks.
I swear there was a table in there that we have used this slide before, but we were going to show the impact of Act 55.
Here.
There is.
Oh, isn't it? Okay. It's in-
Maybe you have to
Thank
click
you.
again.
So we're going to show, and I think Chair Foster's used this slide
Yeah.
before, but really just kind of showing like how we're in this crisis, how has Vermont responded? How have we slowed the revenue growth in the system? So the legislature through Act 55, that outpatient drug cap,
That's the one I was referring to.
as it's, obviously we have to use some modeling to quantify it. That's $104 million out of the system. Hospital budget orders, almost 95 million. And then hospital budget enforcement from prior year overages on top of that, an additional 32 million, gets us to about $230 million removed from the system last year, from what otherwise would have been in there. So pretty significant impact, especially, when you think about the size of the hospital system in Vermont. This is not marginal cuts.
What's the feedback from all the hospitals on this?
It's tough, right? And I think they got the message. I think if you see I'm going to go back here for a second, but you see a lot of these hospitals, right? Northwestern, I'll get to another slide and show that their margins are not great. They submitted a budget below the proposed cap. Rutland did the same thing. I think a lot of hospitals are getting the message that we just cannot keep paying for stuff on the backs of commercial rate payments in the state. It's just, we just can't afford it. So I did I answer your question?
Yeah, that's good.
Okay.
No, what?
So I think we've also used this slide a little bit, but just to kind of to illustrate this, right? So you see the days cash on hand in that left column. A lot of these hospitals are now under 100 days. It's vulnerable by basically any measure we can look at. Northwestern's able to absorb some of these operating losses because they've had healthy days cash, but it's dropping rapidly. It's not sustainable long term. And so really just wanted to show this is a problem, right? You can't, like, the hospital budgets we established this year kind of helped reduce some of the commercial burden in the state, but we need a solvent hospital system. A lot of this we can't just keep doing it with rate increases and some of these margin impacts, right? It's not just revenue feeding into that. There's costs in there too. So it's really like everybody has a role to play in this. And we are, from a lot of hospitals are kind of getting that.
Go ahead, Leslie.
So I'm looking at that slide and just wondering, like, what can we learn from Manascutney and North Country? Why are they in such a more stable position than some of the others like Springfield?
So from this slide, there's enough information on this to directly say North Country has relatively high prices. Well, North Country has high prices.
Mhm.
I think they would come in and justify them. due to their location and whatnot, but, their cash is it's going to drop, right? Mount Scottney also, I mean, they have the advantage of being part of the Dartmouth network. So let me get back to you on that. I'll give you a little more.
Just so you
better
can
answer.
learn, yeah.
Yeah,
If something's working, I want to understand.
I have some ideas. I just don't want to.
Yeah, got it.
I just make the point that it's important when you put together the previous slide that had the budget order and the increases, that's an increase on what they currently are at, and not all hospitals are at the same. So, a 1% increase for one hospital on a high price is going to be a lot more than a 3% increase on a lower priced hospital.
Yes. And if you think about it, I mean, very high.
Percentages don't
I get
equate
it.
to money.
Exactly.
Yeah.
And if you think about it, I mean, theoretically, right, it's going to increase the disparities between when hospitals keep giving the same
Mhm.
growth rates. They starting from different places. So next steps, right? Act 68 directed the GMCB to implement hospital reference-based pricing through its provider rate setting authority as soon as practicable and not later than hospital fiscal year 27. Hospital fiscal year 27, we are actively developing guidance for. So what we're planning to do this year is a transition year to rate setting. Rate setting requires some robust rulemaking and stakeholder engagement. But to get to this, we're no longer going to have the same benchmarks for all hospitals. The benchmark for price growth reduction is going to factor in existing prices. We will have more to speak about the modeling and analytics there. Well, product, I think, I don't want to get ahead of myself. So in a few weeks, we'll have a product kind of available to speak to more about how we're going to do that. But the methodology will be very clear. And that's our goal for 27 is really taking into account existing hospital prices and trying to reduce what you were just talking about, the continued imbalance there. So that was my presentation. I'm happy to talk about any and every, well.
Don't say that.
Yeah, I'm happy to talk to you all.
We have a lot of questions, so.
Questions? I was hoping somebody would ask a question because I had a question, but at the moment I thought about it, I thought it was really important, and now I can't remember it. I think it was. No, I'm not gonna ask that.
I got a question because I'm just confused. Reference-based pricing, is that's going to be on services? Is that going to be on charges for CAT scans, MRI? Is it across the whole spectrum or?
I am not an expert on this. I would much rather have the policy team come and answer this question, but we will absolutely be able to speak to that a little better. Yeah.
I remembered my question.
Yeah.
And it's a good one.
Thank you, Penny.
We need to, Bill, I wanted to get your opinion, or maybe even your expertise, since you are sort of the hospital budget guy at Green Mountain Care Board. We got a bill on our wall, H641. It's a short form bill. It proposes to require all Vermont hospitals to use the same independent auditor to audit their financial statements as directed by the Green Mountain Care Board in consultation with the state auditor. What does that mean? How do auditors, I mean, how do hospitals use their own independent auditors? What does this mean?
Yeah, I mean, I would let the hospitals speak to that a little better, but what we receive in terms of audited financials, they contract with a firm that produces them. They're usually major, Ernst & Young, and they go through the hospital finances and audit them, and we receive that audited financials. What I use that for is to kind of reconcile it against what they submit in our adaptive budgeting system. So what the state of Vermont through adaptive, our GMCB, we ask for is a lot greater detail than the audited financials provide. But there can be accounting differences between how different auditors look at things. I think the goal probably would be to make sure that the reporting is done consistently across all the hospitals, so they're comparable. beyond that, I'd want to think a little bit more about the bill before I give like an opinion on it, but, it. I don't.
Would it be that the board would choose the independent auditor and that would be the independent auditor that does all the hospitals? So you're getting it all in the same format and same,
Well, just very high, what I'm hearing, how I would imagine it working is, I don't know who would hire them, but we'd probably, state would have some way to an RFP or something for to audit all the hospital financials. And then it would be very similar to how we receive it now, just be one firm doing it for all the hospitals instead of,
or
a
consistency,
mix.
maybe?
Yeah.
Okay. All right.
Could I follow up on that?
Go ahead.
So could many auditors, I mean, each hospital now has that auditor, still be required to use the same format, not necessarily the same auditor, and get the same benefit?
That is a good question. I'd like to think on it a little bit more. I'm not an auditor, so I'd like to,
Neither am I,
Yeah.
really, but, you know.
but at a high level, I think, like you said,
I mean, the idea is format. I mean, so that, looking at what the object is.
it's format, but then I'm getting a little over my wheelhouse. I think there can be some genuine differences in accounting principles that aren't wrong, just different.
Mhm.
So I think maybe that's some of the intent is to
Mhm.
control that.
Another question, Commissioner Sampson was in here from GFR the other day. And, you know, GFR, of course, is sort of tasked with insurer solvency. You're tasked with, you know, rate payers and hospital solvency. I know that you receive information from DFR when you're doing your insurance rate review, and I know you're here on hospitals, but is that information like taken into account?
Yeah, yeah, it is. I have to confess, I have been largely not involved with the rate review
Okay.
process. So I think we could have that team come in and speak a little bit better.
Yeah. Okay. Any other questions? Thanks for the great presentation.
Yeah, very helpful.
So I stopped sharing.
What another job, I'm glad I don't. Next, we're joined by Dr. Leffler in his new role. Thought we would invite him in his brand new role.
Congratulations.
And since we were talking about hospital budgets, kind of level set.
Okay. Ready. All right. Go ahead and start.
Yeah, go ahead.
Great. So thank you, Madam Chair, members of the committee. Just so everyone does know me, my name is Steve Leffler. I'm almost a lifelong Vermonter. I was gone for 3 years for my residency training. I came back to Vermont in 1993, and I've been back at UVM in multiple different roles since 1993. The longest being been an emergency medicine doctor at the medical center for more than 30 years. I went to undergrad at UVM and medical school, and I received a master's of healthcare delivery and administration from Dartmouth in 2016. I stepped into the interim role in September during a period of intense challenge for UVM Medical Center and honestly for healthcare statewide. When I assumed the interim role on September 15th, it was very clear to me that we were off track. We were not actually delivering on our mission, which is to serve our patients, our communities, and our state. My first priority as I took over was to stabilize leadership and really refocus the organization on service. We made a number of immediate leadership changes, and we actually restored some power to the local boards, giving local boards of all the hospitals in Vermont, but across the system as well, rights to vote on their budgets and approve their budgets, CONs, and we put the chair of every local hospital board on the network board, which was a thing that was missing and causing the network board to not always know what was really going on in the communities. I think that's going to be actually the most powerful difference. We have a much stronger community voice on the network board now. We already experienced that once in December, and it makes the board meeting much richer and I think much more valuable. Another critical reset that's really important to me is how we show up, how we engage with our partners, our regulators, and our legislators. Going forward, we're going to show up that we are always here in service to our patients and communities. We're going to show up humble. We're going to show up, we're going to listen. We're going to own it when we make mistakes. We're going to collaborate. I'm a collaborator to my core. I want you to know that I've committed that expectation throughout the organization. If anyone, you see any member from UVM Health showing up and not showing up in that way, I want to know about it because we're going to show up different. Please know that what I really hope you take away from today from me is that I want to be collaborative. I am accountable for UVM Health across the 2 states. And I'm committed to rebuilding trust that I know we've lost through actions and not words. I want to share some good news. It was challenging, and we worked all the way through the holidays between late December and January, but we did complete our Blue Cross contract this year. I think that's really important. They have a new leader as well. We've been talking regularly, Beth Roberts and I. We were on the phone, I think, twice this week already. And I appreciate the Green Mountain Care Board data you just saw, but the overall rate reduction for UVM Medical Center, counting the legislative actions last year for the infusion bills, is a 12% overall commercial rate reduction for UVM Medical Center, an 8.5% reduction for CVMC, and Porter's a 0.3% reduction. Overall, if you impact the full all actions taken last year. The next step, and now the really hard work, is aligning our expense base with our lower revenue. And we're very focused on that right now, working hard to get our expenses down to meet those changes. And doing that while protecting quality, improving access. And really, I see the work that all of us did together last year between legislative action, the Green Mountain Care Board, and us is helping make a down payment on trying to make healthcare more affordable in Vermont, but I know we're not done. I do want to thank Mike Smith and the liaison team. They've actually been invaluable partners in both our commercial rate negotiations and our expense review at the medical center. I talk to Mike regularly. I talked to him this week, and he's been very helpful and thoughtful, and I appreciate their input. We have already launched a number of cost reduction initiatives. It won't be enough, and we're going to have to do more. A key example that you know well, we have to figure out how to break even on infusion services. And for some infusions, that's easier than others, but we are very focused on that right now. It's complex work. It's challenging. It takes time to align payment, operations, where you're doing it, and clinical practice. What's ordered, how is it ordered, where you're delivering it, how often, all matters. As I've already said, we know that the reductions started last year are a good down payment, but it won't be enough for Vermont, and we're focused on moving forward. Much of what we're focused on right now is looking to the future, looking to what reference-based pricing would look like for us, and looking to global budgets, which I know is just another couple of years out. I want you to hear that we're committed to being a major contributor to VAS's goal of removing an additional $100 million from the system over the next 2 years. Our focus right now is really on 3 big areas, and I hope you're going to hear this from me every time I come to see you. Number 1 is quality. We at UVM Medical Center has been a 5-star CMS institution in the past. We're not a 5-star institution right now based on CMS data, and we're going to get back to 5 stars, and the whole system is going to get to 5 stars. There's work to do there. There's a lot of lag in that data, but we have more current data internally. CMS is looking at it, but it doesn't actually show up in the ratings for a long time. But I'm confident that we are better today than what our CMS star rating will look like this year. Second, access. We know we have big access challenges. We're very aware of that. I want you to know I'm on an academic medical center board for the whole United States. There's about 40 of us on it. Every academic medical center in the country has some access challenges, but in many places, the academic medical center is one of 3, 5, 7 hospitals in that city or system. In Vermont, every hospital is the only one in CHSA. If you can't get the service here and you can't travel, it's a huge problem. So we're hard at work right now with the medical group on multiple different ways to try and improve access. And most importantly, and I've been there more than 30 years, I've never heard this as one of our priorities before, it's affordability. How can we bring down or slow down the growth of cost of healthcare on everything we do. And when my team is in here, you can ask them, and every meeting I'm going to now, I'm like, what will this do to ratepayers? How will this work for Blue Cross? What are the things we can do to make this cheaper? It's really hard, but it's going to be one of our major focuses. We're trying to set some longer term goals for ourselves. So over the next 5 years, we want to be CMS 5 stars at all sites at UVM Health. We want to be able to break even on as many Medicare DRGs as we possibly can, which is a big push for us right now. And we'd like our primary and specialty care wait times to be below the national average.
Can I interrupt you
Please.
real quick? So I'm certain that, you know, your quality, access, affordability. Historically, what do you think led to sort of, you know, CMS rating down your quality? What have you clearly, if you're working on it, you've probably identified what wasn't working. So
Yeah.
I'm just historically, what do you think it was?
Yeah. So I would say the biggest thing was the pandemic. And everyone's going to tell you the same story. It was the pandemic. But in the pandemic, we lost a lot of very senior people who were able to retire. A lot of our per diem staff and part-timers that had been there for a huge amount of time, had huge institutional memory, could train our new learners, retired. During the pandemic, we were focused on many different things we don't normally do. Vaccinating Vermont, 100,000 vaccinations. Testing Vermont. Constantly opening and closing services, making our peri-op be an overflow space for COVID. Then it wasn't. Then it's the ICU. Then it's not. 25% of our nursing workforce was travelers in the pandemic. And I'm grateful that we had the travelers because they kept us all cared for. But travelers are never going to meet your quality standards in the same way as local people that are there all the time. We changed orientation to become remote. We shortened up some things, and our workforce is less experienced now than it was in 2019. That's the truth. And we have to train them at the bedside. And so this started becoming clear to us at the medical center about 18 months ago when we went from 5 to 4. Problem is it takes a long time to get to 5. It takes a long time to fall off 5. So all through the pandemic, we're still 5, which is kind of amazing. And so we're not putting the focus in that we should have. I think it would have been challenging anyway. And so one of the biggest differences we have right now is we have leadership rounds on every floor, every single week. Every floor has their data up, and we're increasing the scrutiny on when we make a mistake, how can we do better? We're setting, I don't want to call them crazy goals, but I've been telling everyone I want to see 0 falls, 0 health-acquired infections or conditions, 0 pressure ulcers, because you're not going for 0, then you're going to be okay if you get 10 and that's average. So it's hard. It's hard work, and it takes a long time. It's a slog. I was the chief medical officer at UVM Medical Center when we got to 5. What I'll tell you is it takes every single person who works there to be focused on it. Everyone from the CEO to the transporter to the person who's parking your car, because CMS 5 stars grades your overall experience through Press Ganey surveys. It grades all of the care you receive. And so we still have work to do. We're not there yet, but we will be.
Same question, access, where's discreetly are there access issues that you've identified that are particularly, and what do you think is leading to the access issues? Is it productivity? Is it?
So here's the challenge with access. So we'll notice that we have a problem, let's say, with MRIs. So we want to make sure that if you see your doctor and your doctor's concerned you have cancer and they want to order it's called a 3T MRI, a very fancy, highly specialized MRI to help diagnose if you have cancer, the stage of it, and what the next steps are. So I think up until about 2023, there was one 3T MRI in the state of Vermont at UVM Medical Center. We were running it from about 20 hours a day. Okay. And we started having the wait times get too long for you to get that imaging in time that made sense for you. So we went to the Green Mountain Care Board. I'm forever grateful. They understood the need. They approved a second. And for a little while, we were looking really good. We were doing it in a week. And we're doing almost twice the number of 3T MRIs now that we're doing 19, and the backlog is still going up. So more people are needing the imaging. More people are showing up. And I could give you examples.
Why?
Well, what about aging?
Vermonters are getting older.
Yeah.
They need more testing. More people are requiring the really good imaging. I totally get that. If my family member was coming in today, I'd want the 3T MRI for them. And so I could give you examples of colonoscopies where we do all this work to catch up, and then the demand is just always running a little in front of us. It feels like we're chasing the dog and we just never quite catch the tail. Every time we get there, the demand is increasing. I'll talk about that more in a second. I do have some thoughts for some of it. But I will tell you that one of our big access challenges is our demand is increasing for almost everything. We added almost 3,000 new primary care spots across UVM Vermont side in 2025, and we still have wait time for primary care. It's demand. So let me get back. So, I'm sorry. Please.
I'm thinking about staffing. So how do you adequately staff your units in order to did you lose stars because of lack of staffing? And how do you get back to that, a reasonable and appropriate staffing level?
I think it was in 2018. I'm pretty sure that's right. We entered into a staffing collaborative with our nursing union, and now we have it for our tech unions and so on. So we have safe staffing initiatives and goals that we meet. And it's really not lack of staffing. If you look, way over 90% of the time, we meet our staffing initiatives that we've agreed to with the union. I would say it's more who the staff are, and we have great staff. I'm not saying that. They're younger and less experienced. So the trick is our staff, is a little less experienced, newer grads, earlier in their careers, and our patients are sicker. If you look at what's at UVM Medical Center right now for acuity, for that back half of 25, it's as high as it's ever been. Our acuity is extremely high right now. And so you're asking people who are gaining good experience, who are very strong, who are great nurses, but to take care of really sick people that were sicker than they were before the pandemic, honestly.
So do you have programs to try to bring staff in? Yeah, how does that work? Yeah.
Lots of training. So we're constantly training our staff. We're constantly doing, and all of our nurses have education hours built into their yearly salary. We have mandatories. We have impromptu training. We have nursing governance is doing a lot of training. And so, but we're right now, actually, the program that we're doing most is called Back to Basics. How do you manage a patient that has a Foley catheter? How do you manage ambulation with people? We're seeing opportunities at the basic level to make a real difference. So we're very focused on that right now.
Karen, did you have a question?
You just referenced QE and I just wanted to know what that is.
I'm sorry?
Acuity.
Acuity. Oh, how six?
Acuity, I thought you said QE.
Oh, I'm sorry.
That's an acronym I haven't heard.
Yeah.
Got it, thank you, thank you.
All right, I interrupted you.
No, I love the conversation.
I guess.
I love it.
So the 5-star, does that affect your Medicare reimbursement?
It does. It does. That's not the reason to do it, but it does.
No. It is a good reason to do it. It's part of
Yeah, I mean, we should do it because all of us deserve to have 5-star care when we need care.
Yeah.
So the goals we set for 5 years, all 3 of them are hard and really challenging, but I know that pushing us towards those is the only way to get close. As I've already said, this is the first time in my 30 plus years that affordability is one of our pillars of focus. I think we covered some of this. You guys asked me good questions. I do want you to know, and we've already sort of hit on this, that expense reductions alone is not going to get Vermont where it needs to be on healthcare affordability. It's just not. We have to keep Vermonters a little bit healthier. We really do. We have to bring a utilization down. And you should know that for the first time ever in our Blue Cross Blue Shield contract, we have some metrics in it for this year's contract around utilization targets, number of ED visits, keeping people healthier, doing good screening. Hopefully some people need a little less care. One less 3T MRI will matter. We finally have a population health team that is really ready to do this work. So I was part of building OneCare, and there was many good things about OneCare. There was many challenging things about OneCare. The vision was good, but I can tell you that the payment model was in front of the delivery system. The delivery system wasn't totally structured for how to keep people as healthy as possible, which is the only way you can make those models work. We have that now. We really do have a population health organization. We're doing work with UVM, the College of UVM, and our early data shows that we're keeping UVM employees healthier. They need less ER visits. They're needing some less other things. We're helping them with access to primary care and so on. So we have to focus on how to keep Vermonters a little healthier, which is how you say less utilization. We're also extremely focused on physician recruitment. We've already added 80 new providers. I think it's since September. That's a really good thing. We're losing some providers to retirement. And then also in academic medicine, you're always going to have some people that move on. I've been extremely fortunate that my career looks like it's going to begin and end at UVM. I'm very fortunate for that. But many people have a great opportunity to go somewhere else, and we actually celebrate them. That's part of the academic mission. You should always be trying to grow in different ways in your career. So we have added 80, and we lose about 10% of our positions a year. We will be definitely significantly net positive for 25, 26. So looking forward, Vermont is clearly entering a time of profound change and challenge for all of healthcare. Not just UVM Medical Center, not just UVM Health, the whole state, all of our hospitals right now have huge pressures. I say this constantly, we are stronger together as a system. I'm really proud of the work that Vermont did around the pandemic, because in the pandemic, we all worked together, we all showed up together, we all actually listened to each other, we all did the right thing for our neighbors. The hospitals didn't just think about themselves. We shared masks, we shared testing results when we needed to, we shared everything that we had to try and keep everyone safe. I think it's what we have to do now on a different challenge. Unfortunately, it won't end like the pandemic because I think affordability is going to keep us going forward, but we are stronger when we work together. That's both UVM Health, but that's both VOS and all the hospitals in the state of Vermont. My vision going forward is UVM Health wants to support all Vermont health entities, not just UVM Health. We want to deliver the highest quality care we possibly can in every instance in the most affordable care setting, even if it requires partnering with new partners to figure out ways to do that. We want to ensure that patients can move seamlessly from within the system. That's getting easier because we have a single electronic medical record, a single radiology system, but also outside the system. As an ER doctor, I can tell you, if someone gets really good care tonight at St. Johnsbury and gets transferred to us, and they show up in the ED, and I don't have their CAT scan images when they get there, I'm going to order another one. It's terrible. I shouldn't do it. I need it now. I want to see the results. I want to look at the scan myself. I don't have it. It's hard to say, even if what it says looks right, to not get another one. We have to have a system where that flows seamlessly through the system. Really important. We have to be able to do this to have all of our hospitals sustainable. Please hear this from me here. UVM Medical Center cannot take care of everyone in Vermont. We are full every day right now. Every single day we're at capacity or very close. We can't provide all the specialty care in the state of Vermont. We have to figure out how to bring specialty care out to our smaller hospitals for certain problems so that people can stay there in those communities. That'll be good for those hospitals, really good for those patients, but we need it too. We're at 95% occupancy every day. Almost every day this week. It was finally better this morning. We've had more than 10 people waiting in our ED for beds upstairs, which is a huge problem.
Can I interrupt there?
Please.
Because I remember, I vividly remember last year when you were doing a joint hearing with, I don't remember what committee it was. You gave an alarming percentage of people boarding in the inpatient level of care that didn't need to be inpatient. How is that going?
Quite a bit better.
Okay.
Quite a bit better. So at the peak of the pandemic, first off, let's go before the pandemic. Before the pandemic, if we had 30 people in the hospital, so almost a floor worth of patients boarding, waiting for discharge, we freaked out. 30. At the peak of the pandemic, it was 80 all the time. It's sometimes 90.
And remember, you're not getting paid for them.
For a single, and there's people waiting for those beds.
Yeah.
It's going to be the doctor for a second. Not only are we not getting paid, but there's people waiting for those beds. Since the pandemic, we've worked really hard with our nursing homes. Our nursing homes are all doing a little bit better. And so this week it's been in the 30 range. It'll sometimes get up to 38 or 39. That'll immediately cause ED boarders. We get it back down under 30. I'm not saying it's smooth sailing, but it's pretty good for us. And we were in the 20s for some days in December. So it's not perfect, but we're most of the time pretty close to pre-pandemic levels of boarders who are waiting for their next level of care.
And Great, go ahead.
How about the mental health care that's needed that had a lot of borders back in the
Yeah.
day? Is that still?
Please hear this from me. Brattleboro Retreat is doing a really great job.
Good.
They have great leadership. They've really turned this around. Once again, 30-year ER doctor. I can tell you that for the last, not the last couple of years, the last 12 or 13 years, if you had someone come into the UVM Medical Center ED on a Thursday, they needed inpatient mental health care that we couldn't provide upstairs, had to go to Brattleboro. It was Thursday, anytime after 11:59 in the morning. They were not going. We were lucky if they were on Monday. We just knew it. We had them for the weekend. They have totally turned that around. They are doing great.
Good. Great.
They see we have someone, they're calling us, we can take them today, send them down. We have a bed, even Friday afternoons. And it's amazing. So much better. They have good leadership. They're doing good work.
So just a quick follow-up on that. And so transportation has gotten better as well. Is that Brattleboro Memorial? Is that you
We're
all? Is
all
that,
pitching in on
or
that.
not Memorial
And we have a
Retreat?
good program.
Okay.
And so we have a transport program that we're putting some money into. I think they're putting some money into. Somebody else too, Devin, I can't remember, but there's a three-way model where we're putting up some dollars. It's a good investment for us because not being in the ED from Thursday at 11:59 until Monday, paying for that transport's a good deal.
And then mental health urgent care?
Working really well.
Okay.
And so I was curious to see how it was going to do. And the very first day we were setting up, someone said, well, just think about it. This is the person who's going to come in 3 days before they show up in your ER. They're going to come in on Tuesday, get some treatment, maybe come back on Wednesday or Thursday because they can come each day.
Mhm.
And we're going to manage their problems so they don't end up in the ED on Thursday at 3. It really seems like that's working.
Great,
You should know a lot of students are using it. It works really well for students.
great.
It's been very successful.
Okay.
And it is helping keep our numbers down. So our mental health borders is markedly better.
Glad to hear it.
Yeah, can I expand? Not necessarily your mental health borders that we tend to think of in the ED, but I believe some of your borders on the inpatient with co-occurring that you didn't have, skilled nursing facilities that could take people, that was an
Correct.
issue around some of your inpatient.
If you're elderly and you need nursing home care and you have any problem bigger than we fixed your hip and you need help walking, if you have geriatric behavioral health issues, if you have obesity, if you need a really expensive medication, if you have any comorbidity that makes you a challenge to take care for, that's very challenging for our nursing homes. Very challenging.
Leslie, did you have a question?
I'll wait till you finish, since you're.
Okay,
I have 2 questions, but.
we can do whatever.
Keep going.
Finish up? Okay.
Yeah.
So, kind of that vision I just laid out kind of sounds deceptively simple. Like, well, of course, that's what you should be doing. Operationally, it's really challenging, really hard. But that is what I took this role for. That's why I'm here. That's what I'm committed to. I want you to hear this for my last comment. We are ready to partner in this work with all of our communities, our regulator, our legislators, our other community hospitals. We're already starting to do work right now with St. Johnsbury, with Newport, with Gifford, and new ways to partner with them and make sure that some of that care can stay local in those communities. That will be good for those hospitals. Thank you so much. I am convinced that we can do this. We did it through the pandemic. I personally think Vermont had the best response in the United States, someplace I would even say the world. And it's hard what we're going to have to do. Really challenging, and there's going to be some things that are very difficult, but we're here for it. I'm here for it. Thank you.
Tucker.
Thanks for coming in.
Very uplifting. Thank you.
Thank you.
Do you have some kind of a operational governing board within the hospital?
So every hospital in Vermont, including the 3 Vermont hospitals that are part of UVM Health, all have a governance board. I'm not sure that's what you're asking me.
Well, you answered that part. They have a governing board.
So we have a governance board that we present. We have 4 governance meetings for UVM Medical Center every year. I'm still the president of UVM Medical Center. I attend that board with my board chair, who's now Allie Richards, who's Jesse Bridges last year. And 4 times a year, we present operational data, quality, safety, access, budget updates, everything that's going on. And for 2 years, the UVM Medical Center board did not approve our budgets. We've returned that power. It was voted. We started the work in September. It was voted on in December.
That's when Now, the reason I asked that question is, do you have a representative of the nursing group in the entire hospital system on that board?
It's tricky to have nurses who are in the union be fully on your board, but we have Noma Anderson, who's the Dean of Nursing for UVM on the board. Our CNO at UVM Medical Center, Peg Gagne, attends every meeting. And so, no, the simple answer is we do not have a floor nurse on the board, but we do have nursing leadership that attends, and Noma Anderson, who's the Dean of Nursing for UVM, is on our board.
Just a personal opinion. I know Dartmouth had a nurse on the board because it was my daughter.
Congratulations.
And it makes a huge difference in terms of the workforce that you have there. They do a lot of work in the hospital, tremendous amount.
I agree.
And I just think every hospital should have a representative of the nurses right on their board, because they can tell you what's going on the floor.
I agree.
So that's just my
Thank you.
2 cents.
We do have nursing governance. They don't sit on the board, but I appreciate what you said, and we can look into that. Thank you.
Since Topper asked a board question, and I know other people have questions, but I might as well ask now. I think there's a bill in the Senate where the governor gets to appoint 2 board members for every hospital. How do you feel about that?
We already have our community is already on our board.
Okay.
We would look at that. I don't have a strong opinion one way or the other. I'm very confident that the 3 Vermont hospital boards have very strong community representation, very invested. We have great board members. I'm assuming it would be similar people that we already have sitting on our boards.
Daisy, you had a question?
Welcome. I'm glad that you're in your new role.
Thank you.
It's good to see you. Can you give us any sort of assurances that compensation is going to be performance-based and also take into account some of the affordability pressures that taxpayers and patients are facing?
Yeah, I'm assuming you're talking about at leadership levels, I'm assuming. We have a compensation philosophy for UVM Health. And at the highest levels, we have a compensation committee that looks at data for the hospitals, looks at national data, and does our best to try and manage against national benchmarks and the realities of Vermont. And so I'm confident we have a good system in place to work through that. And that board has taken some actions this year. There's no incentive comp in 25. There's no incentive comp in 26. Bonuses, you might say, are not part of that. And they're reevaluating going forward if we would do that, if we would, how we can work with the Green Mountain Care Board, who has some guidelines on what that would look like right now. They're an engaged group. They're very connected and trying to balance that. So I'm confident in that team. They're well, and once again, it's mostly our community board members that are on there.
Is that a new team?
It changes. It changes over time. And so I'm trying to think if there are some new members on there. But the philosophy changed in 25 around some issues of how we're doing things. And I think they're doing their best to manage between the pressure of what the national rates for many jobs look like and what works in Vermont.
Guys keep asking great questions, which lead me to follow up from bills on our wall. I believe Representative McFawn has a bill on our wall, H 585, and I think I remember seeing there's a piece in it around DFR and transparency in hospital provider compensation. Or is it insurer compensation? I'm getting the insurance companies and the hospitals all mixed up today. Never mind. Never mind. I want to ask you about it.
I'm not ready to answer anyway. I would need help. I'm not prepared to answer.
Okay. Never mind. So
I think Leslie was great.
Leslie? And then
Thank you, and thank you for this. I'm not sure if you're willing to share your testimony, but it would be helpful just
We are.
if you're okay with that, that would
Yeah.
be great. There's a bill on our wall about facility fees, and I'm wondering what your thoughts might be about how it would impact the.
So I'm not ready to give real testimony because I haven't seen the full impact yet. I want you to know it will have a major impact on hospitals and revenue.
Mhm.
And so I want you to know that any bill that you're considering this year will come with an open mind. We'll try and figure out and understand how we could meet the demands of that bill, what would be the impact. But there already is a lot going on right now that was taken out of hospital revenues last year. We're still trying to operationalize all that for the medical center between our Green Mountain Care Board orders, the infusion bill, and some other action is $160, $170 million of revenue out. And so I'd love to see us have an opportunity to work through that, digest it all, and make that work before other big things. So we will come with an open mind. We'll carefully look and evaluate it. We're going to have to get more affordable. Somehow I understand that. I will say that one of the tricks with site neutrality is different sites have different cost infrastructure. So care that gets delivered at an academic medical center, you have a 24/7 emergency department, a NICU, you have specialists on call, you have level 1 trauma. That's different than some other sites. And you have to figure out how to cover that expense somehow. But I don't want to go any further than that right now. I want to come with an open, our team will come with an open mind and try to understand how that could work.
Thank you. I'm also wondering, as a result of all this that you've been through in the last year, what your relationship has it changed with the New York hospitals? And can you speak to that?
Thank you. So the most important thing I want you to hear from me is the UVM Medical Center needs New York patients. It's critically important for some of our high-end specialty services, the NICU, trauma care, heart surgery, oncology, neurosurgery. There's not enough Vermonters who need that care for us to have the full services that we have. We need people from New York, that upstate region, to come and keep those services busy and full. And I've heard before people say, well, if they're not part of your system, that care will still come. I strongly disagree with that. We know right now, Albany would love to have all of that care. Rochester would love to have lots of that care. If that care, so if CVPH wasn't part of our system, Champlain Valley Physicians Hospital, and all that tertiary care was leaving, wasn't coming west or east to UVM Medical Center, that'd have a major impact on those services. Either they'd cost more because we'd be delivering it to less people, or there wouldn't be enough care. We wouldn't have the amazing doctors, nurses, specialists that we have to do that care. So academic medical center needs those patients to come. Also, equally important, a strong Champlain Valley Physicians Hospital can keep people in Plattsburgh that are able to stay there, that need to get care there. If all of those people are coming to Burlington, that's the opposite problem. Then we would all have trouble getting in. It'd be over full. My vision looking forward, we need every hospital in the system in UVM Health to be sustainable. We're making great progress in New York on that. We're adding a lot of specialty care over there so people can stay in New York when it's appropriate. And for some things right now, access is improving to the point in Plattsburgh where some people from Vermont are choosing to go there. We're not asking them to go to it, but they could go there for certain things with some specialty care that's been added. So the solution to the question you're asking is to make those hospitals be able to stand on their own. We're not quite there yet, but we're making great progress.
So if I may,
I want to ask a follow-up.
yeah, I guess there was a concern about debt and what the relationship was to UVM and who was responsible for the debt incurred in New York.
So when UVM Health was brought together, ultimately now we're all a single obligated group. So the debt of any one site is the debt of every site. Kind of like your family, kind of like being married if you have one checkbook. Theoretically, I mean, I'm going to keep it simple because I'm a doctor. We have one checkbook. So through the pandemic, there were dollars that were flowing to New York to keep those hospitals running. It's less now. It's not zero yet. It needs to be zero. We're very focused on that. And here's what I don't want to do. I don't want to come and testify to you 6 times telling you why it's important that we have Plattsburgh patients coming to us. I want to make Plattsburgh sustainable, and we're focused on that. And we will get there.
Thank you.
I just want to follow up a little bit on something that you said. So you were talking about, it's important because they help sustain services so that Vermonters can have those services because you don't have the volume. But if we take out the volume, because I saw numbers the other day, Albany Medical Center, their cost of care is so much lower than the University of Vermont Medical Center. Why are they able to provide that care at a much lower cost of care than we can't? That, I mean, because that really is the core question. Why is it so expensive for us to provide care here? And if we don't have the volume, maybe we shouldn't have the care here.
I do think we should have, I do think we should have the care here. As a lifetime person, as part of our academic medical center, I think we're so lucky to have UVM Medical Center in Burlington, so we can all get care when we need it. I've gotten care there. My mother, my father, my brother, both my granddaughters were born there. We have every day I see people whose babies were in the NICU. Not having that here would be a huge issue. It's an economic driver for Burlington and Chittenden County. I'm not prepared today to compare us to Albany. I just don't have Albany's data in my head. It's a fair question. We're working hard on things like that. We're happy to come back, but I would not be able to answer in detail today the differences. I'm sure it's complex and we'd have to look at a lot of different pieces, but we could potentially come back and show you more data. What I can tell you is we're focused on getting cheaper and closer to Albany.
Yeah, go ahead, Daisy.
I really want
And then Lori.
to understand, and you don't have to answer it today, but I think it's a very important issue given what we're trying to do overall with healthcare reform and affordability. Why would you not choose those services that we can't sustain with our own residents? Why would you not choose those as the ones to cut? I simply don't understand. I realize it's a business decision and there's a lot of factors that go into it, but at some point, I really think it's worth understanding because I think that's really key. And especially in the coming couple of years, it's going to be something that the public needs to understand.
Maybe for our academic medical center, if we didn't have the ones I named, NICU, heart surgery, neurosurgery, maybe level 1 trauma, all of us, when we needed those services, would have to travel very far. Our families have to travel very far. I'm not convinced Albany has capacity for all of us to go there when they need us. So some of us would have to go farther. Some of us could, but some of us couldn't. We don't have good transportation. And if you suddenly start eating away at those services, you're not an academic medical center. You're a big community hospital. And one of the things that I lay awake at night most worried about is keep cutting us a little bit at a time. I'm not saying you. We keep eliminating one service that's doing this. We stopped doing transplants is a good example, which was something we needed to stop. Okay? You don't do transplants, it changes who you get for nephrology fellows. It changes who comes for general surgery. It starts to make you, now those doctors can't get that training when they're residents. You start to lose those services, your medical school becomes smaller. You start getting less people wanting to pick those programs. So I hope that the care we deliver is good for all of us when we need it. I've been very grateful that my family could get the care they needed in Burlington. I've been very proud of the care that we get in Burlington. And I think it's amazing that Vermont can have a medical school. I think I've seen some data, and I might be off on this a little bit. I think about 20 to 30% of our residents stay in Vermont. They're not staying here without training here and loving how great it is to go skiing at Stowe or go to Bolton on a night skiing thing or have some outreach programs at different small hospitals. And lots of them stay aren't just at UVM Medical Center. They're staying across the state. They're going to Newport. They're going to Brattleboro. And those doctors are staying in Vermont. I don't think we have that without an academic medical center. So I hear you that it's an investment to have those services. Me personally, to my core, I think it's worth it. We should make the investment have to be smaller, and I'm working on that, but I think it's critical.
Thank you. That is so helpful to understand.
I have Lori and then Karen.
First, I just want to say I appreciate the sincerity that is here. We have missed that for the last couple of years. And I am, as I've said to you before, glad that you're in this role. So one of the things I was struck at over the last couple of years were the number of non-clinical people that you've had at the hospital, specifically in quality care and, not providing the care, but analyzing the quality care and in the prior authorization billing / world. Just curious if there's been any movement on how to make that more efficient and less costly.
Lots of work going on right now. Not quite done. Don't want to talk about all of it, but we are very focused on trying to have as many people. I always say we need a lot more doers, people at the bedside, people delivering care, helping to keep the care safe, and less people, leaders. And so that's a big focus of mine. Lots more coming.
Hi,
Hi.
good to see you again. To Topper's point, you said it was tricky to have, floor nurse or whatever on the board. I don't know. I just quickly looked at this board, this doctors. And I know there are other hospitals with other boards, so I haven't researched all of them. But it does seem like that voice is extremely important perspective to have in all of this work. So I don't need you to, I'm just, anyways, if there's, I don't know where that question is going, other than hopefully there's a way to get that voice on the boards.
I heard you.
I'm gonna say
Jane
that.
Canton's also on our board, who is a nurse.
Yeah.
But I understand where it's the question's from. We will work on it.
And then the other thing was the presentation at Porter and the interface between the two hospitals in New York, Porter. And I know you're all part of the same network, but that was sort of delineated as having some success in terms of sharing, leadership roles and sharing costs and having access, so that you wouldn't have to have so many backup people and so forth. Is there anything to learn from that little 3 hospital system that's applicable larger? And is there anything worth mentioning?
Yeah. So I actually think Porter, Elizabethtown, Ticonderoga. So Porter's in Middlebury. Elizabethtown's right straight across the bridge. Ticonderoga's a little bit south. Is probably the best example we have how well it can work when you truly do really integrate. They share one president for all 3 hospitals, one chief medical officer, pretty sure one chief nursing officer. They have an operations person on the Elizabethtown side. They share providers seamlessly and beautifully. So you might see a GYN doctor might have days in Middlebury on Mondays and Wednesdays, might be in E-Town on Thursdays. They have seamless flow of imaging. So if you need a mammogram, you can call, and maybe Porter can't see till next week. Elizabethtown could see tomorrow. They have really been able to manage the overhead leadership cost structure. Elizabethtown and Porter, both critical access hospitals. Elizabethtown was able to get an investment from the state of New York and some federal dollars and has a beautiful facility, a really nice ER, nicer than Porter's. We're working on that.
So jealous.
Yeah. I was joking when I was down at Porter rounding that in room 1, I was there with a broken arm in 1976. It looks the same.
Oh, no. Oh.
Yeah. So I think, and we've invited the Green Mountain Care Board to go and show what that looks like. I think that's an amazingly well-run tripart system. It delivers really good care to people in that region and maintains access. There's good access at all 3 sites for many primary care issues. They're doing a good job.
Thank you.
We can do a road trip.
Questions? I guess I had sort of 3 questions. I have so many questions. So when the budget orders came down, how'd you respond?
This year?
This year, like, because it was an enormous amount of money you had to pull out of your budget.
It made me, I'm an ER doctor. It made me worried. And then I said, okay, this is our budget order. We have to live with this. And the very next morning, I went and said, okay, how are we doing it? So we started putting stuff together around how we could live within that budget.
If you achieve your budget and are able to maintain some sort of positive revenue, what would happen if they did that again?
Yeah. So I want to say that over the long term, to really invest in what we need, the finance people are always going to tell you need a 3% margin, 3% margin. They've got it in my head. We need a 3% margin to be able to have current modern facilities, keep up with our MRI equipment, keep up with all the stuff that we need. So we're going to be able to get good care of them when we need it. That requires 3% over time. You can go under for a year. Hopefully some other year you make it up a little bit. We changed our margin for this year down to 1. Making 1% margin this year will be very challenging. It's a huge test of our team to do that. But we were focused on it. And so there's reason somewhere between hopeful and optimistic that we can do that. But it's going to take some work. We committed in 2026 to have no impact on patient care services. We know what happened in 25. We don't want to live through that again. The doctor in me never wants to cut a patient service, ever. I want to grow more services. I want to do more things. If we got another 160 plus million out of our revenue stream for 27's budget, we'd have to look at what we are able to do. And I'm not threatening care. I'm saying we have to look at what is our total scope of work and where is our opportunity to drive those dollars out. It's hard. Our expenses are going up. The revenue that is approved right now by the Green Mountain Care Board for 26 is less than we brought in 24. So that's a real challenge. And please don't think I'm complaining, because I'm not complaining. We are going to figure it out this year. If they did it again, I'd probably lay awake 2 nights instead of 1. I'd go in and say, okay, what can we do to preserve the care we're delivering, we're trying to increase care. We're trying to improve access. We're trying to bring on more doctors and nurse practitioners and open up clinic schedules. Under decreasing revenue, that's hard to do. Medicare revenue's fixed. Medicaid revenue's fixed. I think there's things we could do around those revenue streams that would help some. And for Blue Cross, I really hope for 27 we have a value budget with them. I'd love it to exclude us from Green Mountain Care oversight, but that may be a dream. I thought I might throw that in. Yeah. I just thought I'd, yeah. But we're working on that. And that's really keeping people healthier. So we'd work to do it. That's the answer.
I was thinking about this though when Matt was presenting. They had their orders from last year. They removed a certain amount of money from the system. We are still the highest priced, highest premium rates, highest commercial rates in the world. And my thought was, and this is not aimed at you and it's not aimed at UVM, it's aimed at the entire system. And it's really more of a statement that if we are going to ever achieve affordability, there's only so much we can do around, waste or, trimming back budgets. We are going to lose services. And the hope is that we will be thoughtful and we will make, the right decisions over what services are done where for the best quality result at the lowest cost of care, which is sort of to the Albany point, although I'm not saying ship everybody down to Albany, but it's just that this is hard and it's going to be hard for everybody. And we may not get everything we want.
Yeah, so at my core, I'm an academic physician. And if you're an academic physician, that means your whole life, all you do is compare data. You compare yourself to others. How good am I doing? How good is my emergency department doing? How good is my hospital doing? That's all you do all the time. I will tell you that I think Vermont right now, it takes a couple of years to digest everything that's happened in Vermont in healthcare spending over the last little time. I'm not going to tell you that it's still too expensive here. We won't know for a couple of years if we're still the most expensive in the world. It's going to take some time for that data to get into the system, to work its way through, to understand the impact of that. I'm going to go back to the pandemic. When the pandemic started, we didn't know what the bug was. We didn't know how to protect ourselves. We didn't have enough masks. We didn't think we had enough capacity in the system. And we came together and we figured it out. It was really hard, but we brought the right people together every day. Everyone basically rolled up their sleeves. I think there's a sustainable healthcare system in Vermont's future. I do believe part of its utilization. We have to figure out how older Vermonters are healthier. All of us. We have to be a little healthier. That will save more money than anything else we do. I think in that future, we do have tertiary care services. I think we have an academic medical center. I think the medical group, which is 1,000 doctors, part of UVM Health, is able to see more patients, maybe remotely in the smaller hospitals, which is a lower cost of care, and it's really good for those patients. I think we might not be able to add some fancy buildings and bed capacity over the next 10 years, which we'd like, but it's probably unrealistic. But I think we can have a sustainable system. I do. I really do. And so I understand, and once again, I'm academic, so comparing ourselves to Albany, so much is going on right now. And I keep seeing data already for what our percentage of Medicare is right now. I don't want to quote myself today because I don't want it to be wrong, but we have some projections that show it's come down a huge amount over the last 2 years.
I really quick question, only because I forgot to ask Chair Foster, and then Brian, I think online has a question.
Okay.
And then we're gonna end, because we need to end. The settlement agreement, can you just really briefly, the primary care money, has that been distributed?
The primary care money went to, I think it went to Vermont Medical Society, and I believe they're distributing it.
Okay, we know the Blue Cross money was distributed. What's up with the remaining, I don't know, was it 13 million? What is the plan for that?
There was money put aside and some percentage from 0% to 100% of, I think it was 15 million, could be used for consultants to help drive down the cost of care at UVM Medical Center, health / make sure we're as efficient as possible, improve provider productivity. The provider productivity consultant has been hired. They're here for the next 6 weeks. They'll give us a report. There's another one that's happening around, we're not doing the governance one because we fixed governance. There's another one on shared services, I believe, and how we can be more efficient on shared services, which is sort of what you were getting at. And I believe that one hasn't been signed yet. But you should know that dollars that aren't spent for consultants will go back into the system in some other way, which we'll work out with the Green Mountain Care Board. So we're not committed to selling them
There
all.
hasn't been a plan. I was just say, I hope you're not spending 13 million for a 6-week report.
No. It's a tiny fraction of that.
Brian, real quick question, did you have? I'm sorry, I don't have a thing up on our.
Yeah, I know.
Shows people.
And I'm sorry I can't be there in person right now. So we heard the other day about how the artificial intelligence technology is improving the workflow, and that's a way to save money. I'm curious if you're aware of other ways that hospitals and health systems can use artificial intelligence in their finance management or budgeting to improve functioning of the organization, and also just predicting numbers and managing resources.
So, Representative Senna, that's a great question. We actually have an artificial intelligence committee right now looking at all the options out there. There's a million of them. I get another one in my inbox every single day. Right now, I would say most of our focus at this point has been around some things that help the providers somewhat. So we have a really good one that's helping our providers do their notes. I saw my primary care doctor yesterday. My note was generated from artificial intelligence from our visit. Really amazing. It's saving our doctors lots and lots of time and allowing them to see more patients per day. We have a really helpful artificial intelligence tool that's helping read mammograms and some x-rays. And we're starting to look at using artificial intelligence around rev cycle, around prior authorization, denials. I do think there's going to be opportunities there, but at least in those areas right now, what we're understanding is you still need a person kind of watching it and making sure it's working correctly and it's not overreacting. So I think over the next 2 or 3 years, there's going to be things we can't even imagine yet. We'll have to use them carefully and smartly. And so we've stood up a committee to make sure that we're trying to do it ethically and that it makes sense and we don't get unintended consequences. But I think there's big opportunities there for more efficiency on the back end function, which is what I'm hearing you talk about. You know, where can we figure out ways to do things less expensively? It's coming.
Thank you. We'll talk more. Thank you.
Yeah, thank you.
Thank you. Thank you so much for coming in.
Thank you so much for having me.
Thank you. Good luck.
We really appreciate
Appreciate
it.
it. Thank you.
Thank you. And